Hi, I'm Alan Stillman with Stroke Smart Virginia. And as just mentioned, today's topic is on a Stroke Smart medical practice. So as was mentioned earlier, this is my grandmother, Rose. I didn't have a father, lost him as an infant, and I was raised by my mother and grandmother. And when I was 12, my grandmother had a stroke. We had no idea what was going on. We literally waited 4 days before calling 911 and had a horrible outcome. She never spoke again. She never moved again. She became a complete shut-in in her body and left the world that way. My mother, who already struggled with some depression to begin with, went into a deep depression and she overdosed on sleeping pills. I lost both my parents and was raised in a foster home because of a stroke. When I learned as an adult that many strokes can be treated, but they weren't because of time delay, I decided to see if I could do something about it. Professionally, I'm the founder and CEO of QuickPoint. QuickPoint is a design and communications firm. We mostly work with the US military, and the main thing we do is we educate soldiers to find the roadside bombs that are referred to as IEDs, improvised explosive devices. And the thing about them is that they're hard to spot because they're improvised. They can look many, many different ways. So we did some testing and some prototypes with the US military, and we started to find IEDs. And eventually made our approach standard issue, and we found thousands of IEDs all over Iraq and Afghanistan. And while doing that, I started to think, wow, this visual-centric approach to look for things that are hard to see otherwise might actually work well with stroke. And that's what brought me to using visual design to create educational materials to teach people to spot stroke. So for today, we're going to do three things. An overview of Stroke Smart Virginia. I'm going to introduce the concept of a Stroke Smart medical practice, and then I'm going to ask you to consider becoming part of or enrolled in a Stroke Smart medical practice. So some stroke facts. Stroke is super prevalent. There's a 1 in 6 lifetime risk that we all have for stroke. By the time we're 25, it's down to 1 in 4. As we continue to age, it gets higher and higher. 80% of families in our country are affected. What that number means is there's an 80% chance that you, your spouse, your parents, children, or siblings, your immediate family circle, is an 80% chance one of you will have a stroke in your lifetime. Stroke is devastating. It's the #1 cause of disability. It creates millions of people that are aphasic, can never speak again, can never call out the name of their wife or child. It causes people to be unable to walk for big parts of their life. It's a devastating form of disability. More than half the people that get strokes never go back to work. It's just such a severe thing. It's the #5 cause of death in our country, and literally the #2 cause of death in the entire world. The good news is that there are treatments for stroke, effective treatments. Approximately 90% of all strokes are ischemic strokes, and there's two treatments for it: thrombolytic therapy and mechanical thrombectomy. The predicament is, though, it's highly undertreated. Something like about 10% of stroke victims actually get the acute treatment. And I say approximately 10% because it'll vary by hospital and zip code and part of the country, but roughly 10% of the people are getting treated for acute stroke. And approximately 75% of the people miss the treatment window. There's a 3-hour treatment window, which can be extended, off-label to 4.5 hours by the physician. But basically, 3/4 of the people don't arrive in time to get treated. Now, once you get to the hospital, there's been incredible progress, what we refer to as door to needle time, from the time you actually enter the ED to the time you get the medication, which is an IV medication. That's made incredible improvement since this medication became available for stroke treatment in '96. But from the onset of stroke to when people call 911, that's made almost no improvement in 25 years. And so that's the predicament. We're trying to get people to the hospital so they can get treated. So Stroke Smart Virginia was formed, and it has a simple objective: to reduce pre-hospital delay and increase timely treatment. Because even for the people that do get the treatment, 2 million brain cells die a minute. So the faster they get there, the better the outcome they're going to have. So Our initial community partners were cities and counties. We've got about 16 or 17 of them in the state of Virginia, where they've declared proclamations and committed their counties and cities to raise stroke sign awareness. We've got whole school districts, churches, hospitals, EMS organizations, private businesses, lots of community partners being part of this program. So then, why medical practices as a new community partner? So first, what we did is we interviewed some primary care physicians, we interviewed some stroke coordinators and stroke nurses. We realized that we could come up with a criteria to help a medical practice be a better partner or a partner in making it a stroke smart state. Once we developed a criteria, there's something that's called the Virginia Stroke System Task Force. It's the entity under the Virginia Department of Health related to stroke. And we proposed this criteria, we presented it, and we got a unanimous approval for the criteria. We then went ahead working with the Medical Society of Virginia and the Virginia Department of Health, and we came up with a pilot. And we found several hospitals to start working with the pilot. We began with Bon Secours. Bon Secours now has 25 medical practices that are doing the pilot. We got our funding from the Virginia Department of Health. There's been some funding that's flown in through the CDC, and we're moving this along. Within the first month at the medical practices of Bon Secours, we identified 2 strokes that would not have been identified otherwise and got those people to the emergency room. So really early, we started to see some anecdotal indicators that it was working. We've been working with VCU Health at one of their medical practices in Richmond. And there, the best way to describe it is we're really focusing on the micro implementation of the workflow integration. For something like this to work, so many things are happening at physicians' practices, and there's so much pressure to do this and do that. The only way it's going to work is if it's really well thought out, really simple, really clean, and just flows with the workflow. As soon as you make it too difficult, it's just not going to happen. So we're literally focusing on every detail, who touches what, how does it work to make this happen. In addition, we're working with Mary Washington Healthcare. They're in the process of selecting 1 or 2 additional practices that'll be part of the pilot. So why medical practices to begin with, right? You can do so many things. Why not pick one other community partner that we haven't done before? So there's 2 really strong reasons. First, people having strokes call their doctors first. That's a big piece of it, because when you're having a stroke, you often don't know you're having a stroke. You just know that something's not right. What do you do when you don't feel well? You call your doctor, you know? In addition, most Americans visit their doctors annually. We see our doctors. So this makes medical practices a natural, partner for this. Let's drill down a little bit in those 2 ideas. So stroke victims call their doctors first. A 2019 study that was published in the American Heart Association, it's called Reasons for Pre-Hospital Delay in Acute Ischemic Stroke 2019. It found that 1/3 of stroke victims call their primary care physician first. And what happens is they get an appointment. Think it through. Your spouse is sitting there, their balance is off, they feel a little weak, maybe they're limping on one side, something's not right, but you don't know what it is. So you call your doctor. Who picks up the phone? A receptionist, right? Doctors and nurses don't answer phones. And you describe, my spouse is a little bit off. I don't know, what do you think? And what does the receptionist do? Hey, we're going to help you. If you can come in at 5 o'clock, we'll squeeze you in. Come in first thing tomorrow. Come in at 10 to 8. We'll get you. You'll be the first one in tomorrow morning. Well, you just created pre-hospital delay, maybe a couple of hours, maybe 12 or 16 hours. The study said that if a patient comes in and is given an appointment, it quadruples the odds of pre-hospital delay. I mean, of course it does. They're traveling to a doctor's office. Even if they say, come in now, you're a half hour away. It's 2 million brain cells are dying every minute. So basically, the takeaway is do not schedule appointments for people suspected of having strokes. You just tell them to call 911. That's the whole goal. So the second thing is most Americans visit their doctors annually. So this is based on CDC data, an interactive summary of health statistics in a survey between 2019 and 2021. And it found that 82% of the population sees the medical professional annually, whether it's their primary care physician, nurse practitioner, physician's assistant, but one form or another, they see a medical professional annually. And when you think about it, if you're a high risk patient, like you need to go there because you're diabetic to get your blood work, to get your labs, et cetera, you're likely to go even more than once a year to see that doctor. So, you go, you give it, you reach the people where they are at the doctor's office. The other thing is when you're at a doctor's office, you're receptive to health education. You're there because of your health. And more so, your attention is highly focused. When you think about this TikTok generation, right? Social media, apps, things ringing, right? Our attention is hijacked in 27 directions. But when you're there with that precious time with the nurses and doctors at the practice, we've actually got your attention. This is an ideal time to give you information. So the goal here is for the primary care physicians to provide effective education on stroke recognition and the need to call 911. So this is why we pick doctors' offices. So there's really just two practices that make up this criteria. And each of the practices have two actions. So practice number one is do not schedule if you suspect a stroke. If somebody's calling with a stroke, you tell them to call 911. So two actions. Action number one is you train all your staff to spot strokes and follow the practice protocol. Practice protocol will likely be to get a nurse or a doctor on the line, but whatever that practice decides is their protocol. Second, you incorporate scripts into voicemails to spot strokes and instruct people to call 911 when the office is closed or lines are busy. So when you call your doctor's office, if it's a weekend or evening, you get a voicemail. Even if it's during business hours, it's common to get a voicemail. All lines are busy. So you've all heard the traditional message, if this is a medical emergency, hang up and call 911. So we're going to append about 20 seconds to that and say, if you're experiencing facial droop, weakness on one side of the body or slurred speech, this indicates a stroke. Do not wait for a callback. Call 911 now. Because those callbacks can, if you're lucky, they happen in 10 minutes. If it's a weekend or an evening or they're busy, it might happen in a couple of hours. So again, we want to make sure that people are not waiting for callbacks. And the beauty of it is you might say, well, God, isn't that annoying to keep playing those three signs all the time? But there's a really nice benefit of it. In the process, you're burning it into people's memories. Even if I'm calling because I've got a headache or my knee hurts, every time I hear that, facial droop, weakness on one side of the body, slurred speech, it burns it into my brain. There's probably not an American that doesn't have 911 memorized as the emergency number, right? We all have that memorized. Why? Because we've heard these recordings and messages so many times. Let's burn those memories in for stroke too. So that's practice number one. Practice number two is educating the patients on stroke signs and the need to call 911. Two actions. The first one is in the waiting room, have materials. So, and we call that for all patients, essentially magnets, wallet cards, videos playing if you have a TV, posters. So in addition to having Reader's Digest and the golf magazines and whatever else is out there, you have materials that they can look at and take away. The second is in the exam rooms, if somebody's high risk, if you know that person is diabetic, 82 years old, overweight, and a heavy smoker, you know they're high risk, you take a minute or two to explain to them that they're at high risk for stroke, and it's critical that they know how to spot a stroke, and they educate their loved ones. Because most of the time, it's not the person who calls 911 on themselves, it's somebody around them. In the same way that you can't give CPR to yourself, often if you're having a stroke, you don't have the wherewithal to call 911. So it's important that the people around you know how to do it. And so that's the second action, just educating the community to do that. And in terms of, I mentioned that VCU Health is working on the micro implementation. What they're doing is literally they hand you an envelope. In the envelope is a stroke card, a magnet, and an information sheet. Everyone going through just gets that. Hands down, if you walk through that office, that clinic, you've been educated how to spot a stroke, or at least given materials to support that. So then the question is, why should I take the time to do this particular program? There's so many different things that physicians' offices can do to educate the public. Well, if you remember the prevalence, right? Over 25, 1 in 4 people. Number one cause of permanent disability, right? This is a major public health issue. This is not a rare disease. So first thing we can do to make it easier is everything's free of charge. The magnets, the posters, video materials. In fact, if you like, we can even brand it with your practice's name on it. So it becomes just another, almost kind of a marketing tool that you can give this out to your patients. Second, the program is designed to have minimal resources required of your practice. The most important thing is it requires no provider time. We get how precious those minutes are with your patients for the providers. So it requires no provider time, and it requires a relatively small amount of time for your practice manager to set it up, and then the training for the staff. The training is free. The training takes a half hour to an hour, depending on how you want to do it, but relatively simple startup, works right into the flow, no provider time. Third, improved quality of care. VDH has a way of measuring this through looking at some of the metrics and the stroke registry. So we can actually come back to you in a year or 2 years and say, guess what? You've helped so many patients get better outcomes and compared it to other practices that haven't done that. So you can actually kind of get evidence that it's making a difference, and that'll be done on the VDH end. And then in addition, if you get a win, if you spot a stroke of somebody calling in, let us know. Let's celebrate those wins. And then additional incentives, and these are being worked out now, they're not happening quite yet, is we're all going to be able to give, we hope to be able to give maintenance of certification credits, MOC credits, and we also want to have a certification called a Stroke Smart Medical Practice and look at public recognition. So we really want to make this as positive and much of a win for everyone. So to take it a little bit full circle, I talked in the beginning about how I was involved with the military, helping them find IEDs in war zones. And I can tell you firsthand, one of the most meaningful things in my life in this time in this world is I had a soldier come up to me and he gave me this big bear hug. And he just said, Alan, because of the IED educational material, I spotted an IED. That IED never went off. And I and 3 of my buddies are alive because we spotted an IED because of the materials we were trained with. And then a couple months later, I met with the colonel. He was responsible for putting out several 100,000 of our pieces in Iraq to all sorts of soldiers, going into different combat zones. And he looked at me and says, Alan, you have no idea how many boys and girls went home with both arms and both legs because of the IEDs we found. And literally, he started to tear up, this colonel, and said, on behalf of our nation, I want to thank you for what you and your firm have done for our country to save lives. Well, I can tell you, when I think about the things that I remember in my life, feeling to have made a difference like that is right at the top of it. And my hope is that you, the medical community, can have that same feeling when someone comes up to you and says, you know what? Thank you. We spotted a stroke in my grandmother. She's still with us. I spotted a stroke in my wife and my husband. They're back at work. My family is still together because we got them to treatment, because we got the education, because that doctor said, no, you don't need an appointment. Call 911 now. Your wife is having a stroke. So I want you guys to have that kind of a feeling. So to get actively involved, and I believe this is going to be pasted into the chat box, there's 2 different ways you can get involved. One is the Medical Society of Virginia has has created a survey. And the survey basically is a 5 to 10 minute survey, and it just allows you to help shape this ongoing pilot, just to give us input on what you're thinking about this and what would make it most effective. And the second is, if you're interested in becoming part of this pilot, to get more information. So you can either email myself, Alan at QuickPoint. You can email the Medical Society of Virginia Foundation's email, and we can get you going and give you the information you need to make a decision or to move forward.